All right, we're going to get started. Welcome. Thank you all so much for being here to the second Stretch National Convening, titled Say What? Say Huh? A look into bidirectional communication through a health equity lens with public health practitioners. My name is Valerie Henderson. I will give you all a brief description of myself. I am an African-American female. Today, I have my hair slicked back in a bun. I have on gold earrings, a black dress, and a denim jacket. We're going to go ahead and proceed with today's convening. I would first like to start with a land acknowledgement. During the land acknowledgement, our hope is to better understand the history of the land we currently live, work, and play, honoring and showing respect to Indigenous peoples who have and still continue to occupy the land that we live on today. So if you have time, please enter your zip code to the number listed here, 855-917-5263, or you can visit the link in the presentation below. I would also like to mention we do have somebody who is online. If there are any accessibility needs, please direct chat Autumn Woodbury if you have any additional accessibility needs. We do have ASL interpreters here today as well. Thank you all so much. I would like to start by going over today's agenda. So what will we do in today's convening? We'll start out with some welcomes and introductions. We will then have our presentation from our subject matter experts. We'll give you all some time to connect towards the end, and then we'll have a closing.
We have some issues, so that's good too. I mean, really, at the end of the day, it's
Okay. And I'm going to turn it over to Jessica to introduce what is Stretch.
Great. Thanks so much, Valerie. Welcome, everyone, to today's convening. Before we dive into today's presentation, I wanted to do some level setting around the Stretch project and both of our iterations. So we are funded by the Robert Wood Johnson Foundation. And for those who don't know, Stretch stands for Strategies to Repair Equity and Transform Community Health. So the Stretch team is made up of 3 organizations brought together by Robert Wood Johnson: ASTHO, the CDC Foundation, and Michigan Public Health Institute. The initial aims of this project were focused on providing targeted technical assistance to state agencies to aid them in operationalizing equity. While the term operationalizing equity is broad, our project emphasized assistance in areas such as creating sustainable funding strategies for health equity work, developing and implementing an inclusive workforce, and advancing leadership capacity to promote practices and policies that advance equity, ultimately establishing and creating a culture of equity. So in order to achieve these project aims, the Stretch team developed the curriculum for a 10-state learning cohort. The first iteration of this cohort ran through the 2022 calendar year and concluded in May 2023. The primary objectives of this learning cohort were to design meaningful, lasting systems change to create inclusive, equitable public health systems, embed equity into priorities, programs, policies, and practices, and leverage new funding through finance strategies to drive impact. Next slide. Thank you. On the slide, you'll see listed the 10 states who participated in Stretch 1.0's learning cohort. As part of their application, participating states were asked to create Stretch teams for each state that included at a minimum the following 4 core members: a state health official or designee with decision-making ability, a minority health or health equity director or lead, a community engagement leader designee, and a community partner or intermediary agency lead. The RFA also included a statement of participation agreement that the state's official had to sign off on, which included developing a Stretch state team, like we talked about, developing a work plan and identifying technical assistance needs, and participating in Stretch learnings and meetings. Later on in today's convening, you're going to hear from some of our Stretch 1.0 participants about how their work has been impacted by Stretch. Next slide, thanks. In preparation for working with these state teams, the internal stretch team developed this framework that you see here, which was developed to inform the learning community offerings. The framework is centered on addressing root causes of health disparities through a systems change approach and is meant to reframe and reimagine current public health models necessary to achieve more equitable outcomes. At the center of the framework is addressing the root causes of inequities such as structural racism. Fully addressing these causes can only be achieved if all three levels of systems change are addressed. This includes the structural level, such as policies and practices, the relational level, which is relationships and power dynamics, and the transformative level, or mental models. To achieve these levels of systems change, the 5 subject domains of the framework are interlapping and necessary functions. Community-led approaches focuses on centering community voice and equity work and can be used to address issues such as disempowerment, abuses of structure and authority, or addressing the availability of employment and livable wages within a community. Place-based initiatives focuses on work centered around a shared geographic location. Within the stretch framework, this work can include addressing residential segregation, environmental hazards, food deserts, and transportation access issues. Workforce development focuses on providing the proper organizational structure and training to those working in this space in order to increase impact and effectiveness. Another component of workforce development is ensuring hiring practices are equitable and where possible, the staff representation reflects the communities they serve. Data-driven management addresses the need for more equitable collection and dissemination methods when it comes to data and equity work. Oftentimes, communities are asked to share data, but are never told what is done with it or what actions resulted from their participation. And this can often lead to mistrust and feelings of resentment, as well as a desire to not participate in future asks. Finally, finance systems looks to how agencies can organize finances for long-term sustainability and success. The finance systems domain focuses on how governmental public health can move away from restrictive approaches, such as funding streams based on pre-existing silos. It encourages organizations to adopt approaches to match community needs and priorities and move away from traditional restrictive funding mechanisms. Depending on where the stretch teams wanted to begin their work, they could focus on any one of the domains in any order of their choosing. By addressing each of these domains, the end goal of the framework is equitable outcomes for all. So one of the primary lessons learned from Stretch 1.0 was that community partners needed to be more directly involved in the work of Stretch. Therefore, when developing the project's second iteration, the Stretch partners focused on centering the community partners. In Stretch 2.0, community-based organizations were the primary applicants for each state's submission. Along with receiving funding to assist in participation, each stretch applicant is comprised of a partnership between the applying organization and their state health agency. This partnership comprises the Stretch Collaborative, who receive personalized assistance through their core response teams. The 7 collaboratives who are participating in Stretch 2.0, we have Colorado, Hawaii, Maryland, Nevada, Rhode Island, South Carolina, and Vermont, make up the Stretch cohort, who together participate in peer learning through the project's practical application workshops. The third level of engagement is open to all those working in the health equity space who would like to learn more about Stretch and the lessons learned from these initiatives. So that brings us all back around to our convening today. This is currently the second of our Stretch national convenings, and today we're going to be discussing bidirectional communication. Along with applying the Stretch framework and hearing about lessons learned from our project, another primary goal of these convenings is to serve as connection time between health equity practitioners focused on systems change work. And with that level setting underway, I will hand things back over to Valerie to talk about today's session and speakers.
Thank you so much, Jessica, for giving us a wonderful overview of Stretch. Today, I would like to introduce you all to our speakers who are here with us today. Thank you all so much for sharing your time and your expertise with me or with us. So first, I would like to introduce Dr. Melissa Green. Melissa Green prepares clinicians and other leaders to advance health equity as a researcher and administrator at the University of North Carolina at Chapel Hill. She is the project director for Whole Community Connections, a leadership capacity training program for community academic teams and the former Deputy Director for Recruitment and Communications for Clinical Scholars. Next, we have Jade Ramsdell. Jade is a seasoned leader with 8+ years experience in project management, quality improvement, and organizational development. As Performance Improvement Director at the Kansas Department of Health and Environment, she enhances public health strategies, addresses health disparities, and leads state health initiatives. In her free time, she enjoys art, travel, and spending time with her daughters. Next, we have Godwin Wando. Godwin currently works for the state of Nevada as Community Wellness Manager in heart disease, diabetes, and stroke prevention. He is focused on managing both the health disparities, heart disease, and diabetes grant, and is currently the DPBH Language Access Coordinator, Tribal Liaison, and DEI Advisory Group member of the state of Nevada. He is also an executive officer for Charlie Medical Community for the Oregon Army National Guard, and he has been with the Oregon Army National Guard for almost 13 years. These will be our 3 speakers for today. Please give a big virtual round of applause. We look forward to hearing from Dr. Melissa Green and Jade and Godwin as our Stretch 1.0 previous participants, but so happy to have them back here today. And with that, Dr. Green, I will give you the floor. Thank you.
Thank you, Valerie. I just want to invite folks to help me provide a virtual applause for Valerie Henderson, Dr. Jessica Feppelstein, and the ASTHO team for coordinating and kicking off today's session. I'm thrilled to be with you here today as I share some considerations for being more intentional in your bidirectional communication and helping to facilitate a discussion with Stretch 1.0 participants about their experiences with bidirectional communication. So as we begin our discussion, I'm reminded of a phrase shared by Dr. Ellinger in the first Stretch convening, which reminds us that we all do better when we all do better, right? Simple. And it really is I think helps us kind of think about the context of if we're truly committed to creating impactful change that results in health equity in all the spaces where we work, where we live, and where we play, we must communicate and co-create our work with collaborators who can help us leverage change. And our focus today is around bi-directional communication. And what we mean by that is communication in which collaborators listen to each other with intention, share insights with each other, and make informed decisions. And so I'd like to offer an example that comes to mind as I think about our convening today. So good bidirectional communication to me is like a dance. So imagine, if you will, 2 dancers who grab your attention as they dance effortlessly on the dance floor. So each dancer responds to what the other dancers' movements are on the dance floor, right? Good dancers move both independently, but also in smooth unison. And maybe less experienced dancers might move in less smooth, maybe more robotic steps that appear clunky or uncoordinated. One partner might even step on the foot of their partner. And so whether your vision of dancing was salsa dancing or ballroom dancing or square dancing, it takes practice and intentionality to dance with smooth effort. Similarly, good bidirectional communication is like good dancing. Partners are listening to each other, they're checking in, and they are engaging in transparent decisions. So, and some considerations as we think about that from an equity lens, and obviously you're thinking, who's leading? Who's leading in this dance? Who's choosing the song? Who else is on the dance floor? And how are we sharing space and decision making? And so while those dancers are dancing, they need to be mindful of who else might be on the dance floor. as they're sharing that dance space. And as the DJ might play a new song, like maybe a line dancing song, all those dancers are dancing individually and in unison with a larger group. So as you think about that example, how do we bring the idea of dancing in unison with our collaborations with health equity collaborators? Bi-directional communication with existing collaborators can help us build mutual understanding with folks who are already working with, use the same language so that we're clear about what we're talking about. It can also be helpful in motivating our collaborators to work together to create and enforce policies and practices that support health equity. And that bi-directional communication can also be helpful with new collaborators by bringing new expertise to the table. As public health practitioners, all of us on the call from all over the country, I think there are more than 200 folks who might be joining us today. We tap into all the available strategies that are available to engage collaborators. Those include one-on-one meetings, town hall meetings, but also tapping into some of the virtual spaces like social media and similar mechanisms for a medium for engaging folks virtually. So for some of us, that might be op-eds, media interviews, or even technical reports. And so I'd invite folks who are joining us today to use the chat to let us know what are some strategies that you're using for bi-directional communication in your communities. And as you continue to add those into the chat, you know, like I said, we're living in a time where we can take advantage of both one-on-one strategies, like the one-on-one exchanges, roundtable discussions with our advocates and practitioners and policymakers to make decisions, but also taking advantage of some of the virtual strategies like one-on-one that can include one-on-one interchanges and group focus interchanges, but they can also include email, social media, and Zoom like we're using today. So we're going to hear several examples, but I just want to share one that comes to mind from one of our clinical scholars, Thaba Mahadevan in North Carolina. And Thaba led the development of a tiny home village setting in tiny home village in central North Carolina. And this was specifically developed for individuals with severe mental illness, or with mental illness, and also for veterans with chronic health conditions. And the aim was creating a model for affordable housing. In this case, the tiny home village design was created by having listening sessions with individuals who had mental illness, who helped define, first prioritize that housing was a priority for them. And then they also were a part of helping to define like what success would look like in a housing community for them. And that would include things like having an opportunity to socialize and to be able to retreat when needed for self-care. It also involved bringing builders who would help create, you know, the physical space that adults would live in, and working in collaboration with the state Medicaid office for insights about what does it look like to feasibly have affordable housing that also meets the needs of adults with mental illness and veterans with chronic conditions. And so it's taken several years to reach this effort, but the product is a model that includes housing for adults with mental illness. That is a space that these individuals can age into. It's also a space that provides a sense of community and self-care, and it also provides an affordable. Affordable housing for individuals who are living on a fixed income and dealing with a multitude of health conditions. So as we pause from that example, let's transition to our panel with Stretch 1.0 participants to hear some more examples. I believe we have Godwin, who is going to join us in the panel space, and Jade.
I am here.
Great. Welcome, Godwin.
I am as well. Hello.
Wonderful. So, Godwin, can you start us off by sharing with us a time when you've applied bidirectional communication strategy in your work environment with the many hats that you wear, whether it's been an in-person setting, a written setting, or even in a virtual setting?
Yeah, absolutely. And I will start both by saying that it's a pleasure for me to be here today to talk to all of you about really Stretch, which I've absolutely enjoyed, both the 1.0 and the 2.0 iterations. And then kind of start from 1.0, kind of how bidirectionally we began our process. And you could see here, I actually have my Stretch project board in the background because we had to figure out exactly, okay, what did we need really to better even be able to understand what it is that we um, really needed to understand. So we don't know what we don't know. How can we figure that out? So Stretch was very instrumental in really helping our workforce development within our health equity unit, which was really created because of the health disparity grant that I believe all the states received starting in July with some, I guess, the American Rescue Plan dollars. But to go into your question, Melissa, specifically, is once we got a better understanding of health equity, specifically in the state of Nevada, just as in a macro sense, we then really needed to understand how can we address really some of these health disparities, specifically within the communities, whether it's rural, whether it's with some of the racial and ethnic minorities, and then a variety of other individuals that fall in long lines of just historically marginalized individuals. And so what we had to do is talk to the community. And it's interesting what Jessica mentioned with the really community-based approach and place-based initiatives, because a lot of that involves with the general bidirectional communication, because we have to talk with and have those conversations with our, I guess, really those stakeholders to better be able to understand what policies we can put in place, especially to improve health. And so with us, it was two parts. Well, it's multiple parts, but I'm only going to talk about two today. One was working on a health equity action plan specifically for the entire state of Nevada. And I'll drop it in the chat later, but it was really worked with, most of it really done by the Nevada Minority and Health, the Office of Minority Health and Equity, that with some of the dollars was able to go into the different communities, different poverty populations of racial ethnic minorities, LGBTQ, the rural tribal nations as well, and really sat down and talked in focus groups, see what is it that we need as a state to be able to reduce health disparities. And so that bidirectional communication, we had some virtual, but as the pandemic was subsiding, we were able to open up and actually have some in-person conversations. And it was with that, we were really be able to come up with a plan that truly interacted with really all of Nevada, not just Nevada that tends to get all the resources. But then secondly, and it leads to what Jessica mentioned about data-driven, really data-driven approaches. And it was our work doing community-based participatory research with UNLV, specifically both within the grant, so we can be able to apply it within a CDC federally recognized grant, but then also to be able to get that guidebook to the different organizations, regardless what grant they had. And it was really able to allow partners to really bridge that divide that tends to happen with the research-based research end, as well as with the participants, to really be able to have a collaborative and equitable approach to research, so that there is an equal share of power between the research and the community. So very long-winded way of saying we have done bi-directional approaches, at least to my understanding, in the state of Nevada.
Well, wonderful. Well, thanks for threading the Stretch 1.0 and 2.0 components as you shared your examples. And so I'm gonna come back and ask some additional questions, but I'd like to leave some space for Jade to share an example or two that from your work, Jade. Can you tell us an example of applied, where you've applied bidirectional communication and the work that you've done through 1.0?
Yeah, absolutely. Much like Godwin kind of described, our work catalyzed with the help of the COVID-19 Disparities Grant. And so our office was developed and we were able to really spread our wings. Now, stretch was a huge component of that, no pun intended when I say stretch. In the regard of spreading our wings, but it was really beautiful for us because we had a dedicated work plan that served as a guiding light. It was very difficult in the beginning portions of kind of our work to really establish what our values were going to be, our mission, our intent, because instead of being necessarily a dedicated health equity office, we were integrating things like reaccreditation, which involves a considerable amount of health equity components, and quality improvement, where you're adding in that quality improvement and health equity lens and various different things out of our office. And so Stretch provided us technical assistance, guidance, kind of gave us a permission to fail forward in times where we really weren't sure if we were going in the right direction. And it was through the convenings and speaking with other states on the experiences that they were having, which were very similar to our own, where we were able to really be triumphant and navigating through some oftentimes muddy waters. And so in terms of bidirectional communication, as that started to flow and we really got going with our stretch work, we began to think about how we communicated with the community differently. And what I say by that is really ensuring that the information that was brought back to us as a department that we actioned on, whether it was favorable or not, right? And so that requires a considerable amount of humility. We did that through town halls, community conversations, learning collaboratives, what we call local health equity action team meetings, which happen at the community level and can include folks from with lived experience from our federally qualified health centers to health entities, nonprofits, community-based organizations, you name it, all of us sharing space to talk through what's happening and how we can really address health disparities. And beyond that, holding dedicated office hours, because we understand that coming into a space where there is an ask, especially as a state entity, can be very challenging, but it shouldn't just be that we're coming to ask for something, right? There's not only is there bidirectional communication, but like there's benefits in many different ways. And so for us, it's just remaining clear with what that ask is, but also ensuring that our communication strategy outlines what folks are contributing to the space and letting them know that they're valued throughout the process.
Thank you, Jade. So many nuggets in what both of you have been sharing. Jade, some of the things I'm taking from you is one, engaging collaborators in identifying what your values will be as a new health equity center. The office hours is certainly a way to have that bi-directional communication, and learning from other states who might be experiencing some other similar challenges and issues. I wonder, Godwin and Jade, if you could share kind of a specific example of what you might have done a little bit differently to more intentionally apply a health equity lens to your approach in welcoming and leveraging voices from collaborators in your across the state, and also maybe how you continue to keep collaborators, because from both of your examples, this wasn't an overnight thing. This has taken quite a bit of time. So how could you kind of talk about like how you specifically have engaged voices from collaborators and how you continue to keep them engaged over time?
I can go first. Definitely lessons learned, and there were plenty. And I think it was something initially identified and having stretch in the first place, which is that a lot of the work that is being done, especially recently involving health equity, is very much unprecedented. I know really even throughout the entire state of Nevada, I would say we probably multiplied the amount of people working with health equity specifically by at least 500% just by just the different people with the different organizations that we were able to, I guess, infuse grant dollars with, which is also a thing, which is part of Stretch 1.0, was also the ability to find and maintain sustainable funding. But and obviously that's you can't really help that, but certainly being able to have a better way to organize and use your workforce is certainly something that we can and continue to try to work and be better at. And I think one of the ways, especially as I transitioned from my old role with health equity, specific to now working with heart disease, diabetes, and stroke prevention, is the use of technological aids to really have that real time bi-directional approach. And it's not just with us, but also kind of working with providers in order to implement that. You're lucky enough to obtain a grant that allowed us to be able to invest into those types of technology. And so we are working diligently with the state to try to implement that so that we can have that real-time communication. Because right now it's not something that we currently have, and I think it would certainly be helpful, especially when it comes to identifying people with prediabetes, with heart disease, with, to monitor and their blood pressure and things of that nature.
Could you say a little bit more, Godwin, about what specific technical aids you're using or you're planning to use? I think that our folks who are joining us would like to hear some of those, specifically what that might look like.
Yeah, I mean, I know it's very new, but at least it's very new with us. So we do have a Nevada 2-in-1, which, definitely tries and works on trying to be bi-directional. It's an attempt to really be able to have providers be able to work within the system of Nevada in order to be able to obtain the resources they need, right? But how do we know that they received it? How do we ultimately get those individuals who we said, hey, why don't you go here to be able to a nutrition coach, for example, or be able to find a provider who could be able to deal with those issues that you may have. And so we've been working with essentially working with different organizations and creating an RFP to be able to have essentially a bi-directional social system that will be interactive, or that could be in a person's cell phone, so literally in their hands, to be able to have that communication with their provider, specifically on prevention issues that we in the state are attempting to measure.
Thank you, Godwin. Real time and mobile. So
Yeah.
That's great. All right, Jade, would you like to offer some insights about how you're applying health equity approach in your bi-directional communication, or some new insights over the evolution of your work with 1.0?
Yeah, absolutely. Of course, acknowledgement of those opportunities is so critical to the process, and so continuously asking ourselves those questions it has been really important. But also ensuring that we're actioning on them, and so it really surrounded cultural responsiveness for us, and making sure that we are culturally tailoring communications was a real opportunity. We took on what was a quality improvement kind of framing to better understand where we had area for opportunity in that regard, and ended up implementing an enhanced culturally and linguistically appropriate services program as a result of our stretch work, because we saw this as a way to ensure that bi-directional communication also was accessible as it could be. We're a pretty linguistically diverse state, with 105 counties or so, and so that's a lot of ground to cover to ensure we're meeting everybody where they are. In terms of keeping folks engaged, and even ensuring that a health equity lens is incorporated in that, similar to what Godwin said, it's really looking at ways in which we can leverage the tools that are around us, and ways in which we can be collaborative, right? Technology is one way of doing that. And so I'll speak to artificial intelligence, which is being used quite a bit more within, many fields, but also specifically for like taking notes and things like that. That way we can maintain our specific dialogue, or when it comes to specific presentations that we have, data visualization when it comes to GIS mapping and ensuring that we're really telling the story of what's happening within communities, or when we're getting feedback from communities on this is what it really looks like, ensuring that they're at the table when we're developing that kind of content. What do you want it to look like? How does this tell your story? Because it's not ours, right? Um, and then just tracking when we are doing that tracking and monitoring of our progress throughout. What ways can we be communicating that back and ensuring that that line of communication stays open? And so we've utilized GIS mapping to truly tell a story of, okay, here are the communities throughout the state that we're engaging with. And so we have this visualization map that shows you here are the entities that we're working with. Here's the different places within the state that we're working with them on different projects. And then you really get to see where those gaps are, so we can dive in a little bit deeper to say, okay, this is an area where we haven't been able to fully support.
No, Jade, I like that, especially, and that's something in which we've certainly have tried to do as well, with really interacting, really all the different parts of really the state of Nevada and all the different resources that exist, from like senior centers to diabetes self-management to diabetes prevention, monitoring blood pressure and all those things. There's a map for that for us too.
And it's like you said, Jade's maintaining or taking advantage of the newer technology. Like AI it's with us to stay. So figuring out how we're going to leverage that technology to help us in public health. And so it looks like Christina has joined us as well. So we may have some additional insights regarding participating in engaging collaborators in health, using a health equity lens to leverage those voices. And I wonder, Christina, we started earlier with first an example of how you might be leveraging bi-directional communication in your communities. So would you like to share an example?
Yeah, sure. Can you guys hear me?
Yeah.
Okay. Hi, everyone. Sorry for being late. I think one of the best ways or biggest examples that we have is that we have monthly meetings with different community coalitions that we call local health equity action teams that are comprised of community residents, organizational stakeholders, and community health workers. And our team actually participates in those meetings as technical assistance providers. And so we get to hear from our grassroots and grass tops individuals about, what is really happening on the ground and what are the challenges they're facing and how are they innovating to overcome those barriers and challenges. And so we also partner really closely with Jade and the state, our state partners. And so that information also gets filtered to them as well, which they in turn can then utilize in their planning across the state as well. So from the community to us to the state, so and back down.
Wonderful, and it's good to have the perspectives of folks who are working on this, and this, you and Jade, who are in the same state and working on developing your health equity plan across Kansas. So thank you, and thanks for joining us. I wanted to transition just to a question about some of the products that have come out of your collaborations. Once upon a time, I worked with a program called Community Bridges to Cancer Clinical Trials. And what we thought we were going to do, we knew we were going to have 3 modules at the beginning of the program that had clinical trials education, and how those developed over time changed because of our collaboration, having bi-directional communication with our partners, who included local cancer education organizations. So I wonder if you could share how some of the processes or products have changed as a result of having bi-directional communication with your partners in Nevada and in Kansas.
Yeah, I actually dropped a link of our working with our Access to Healthcare Network, or essentially a map of kind of where the resources are, and I think that's something we found, that there tends to be a gap. With the gaps of health disparities, there tends to be a gap of information and knowledge of where to go when you're dealing with specifically in where I currently work in now, chronic disease, but it could be really behavioral health resources, HIV resources that, you know, involve even like public health preparedness and those types of things. And so I think ensuring that the products are accessible, interactive, and then also provide the information that's necessary without necessarily trying to talk anyone to death is extremely important, because our the resources that we at a time that the people we serve have are limited because they have lives. So it's truly trying to understand you know, how can we best be able to have interactive really communication. And some of the best interactive communication is when it's bi-directional, as that someone is talking at you, kind of like how we're doing right now with you all. It's probably a little less interactive than when we are in a meeting and we're having that conversation and you can feel engaged and not necessarily have the excuse necessarily to check out. So I think creating those systems technologically as well, then certainly kind of going back to that mobile app and really even the community-based participatory research products with the Nevada Minority Health and Equity Coalition that they have. That we were lucky to be able to work with Stretch 2.0 to be able to try to expand is kind of really what we want to do, to really have the community understand that we're not just here to collect a paycheck. We're here to serve the community.
Yeah, I'm happy to add a little
Thank you
bit
for
to
that.
that as well. You know, I think one thing that this process has really done for us is really had us examine what we do at the start of a project, right? And so we get a lot of feedback, and of course, our partnership with Christina and the COPE project has been instrumental in this. But about, you know, coming in midway through a project and trying to collect feedback, right? But what are we doing at the start of the project? And so now we are asking ourselves, who's not at the table before we even begin to delve into things, and that's been pretty critical to our success. You know, our programs and interventions are becoming better tailored to meet specific needs and preferences of community, and we're understanding throughout this process that that doesn't just stop after you know, a few times of doing so. It truly is continuous, and so we're never afraid to just continuously update our processes based on the feedback that has been provided to us. We've seen that a lot with you know, projects where we're working on, whether it be like funding navigation or, you know, rolling out different action plans, food security initiatives, you name it. That's a way that our bidirectional communication has really helped to foster and ensure that we are addressing things from with a health equity lens. And then, of course, always in ensuring that we're incorporating diverse perspectives. Again, I mentioned we're a very increasingly diverse state. Linguistic diversity is something we always need to take into account. And so we want to be as respectful as we possibly can of different cultural contexts. And so it also requires education, learning, and giving that back and ensuring that we're being thoughtful about that with our not only the products, but you know, different presentations that we might be having as well.
Thanks, Jade. Christina, would you leave some space for you if you'd like to add some tidbits to that?
Yeah, I put one of our products in the chat. So we are really big on making sure that community voice is actually heard in the products that are developed. And it is usually they're the ones as the messengers. Like nobody really wants to hear me talk about health equity, but to have somebody from community do, you know, that kind of dissemination of information and talk about it from their perspective is really what makes a change and an impact. And through teaching our communities about public health and social determinants of health and things that they know exist, but maybe don't use the same language to describe them as we do, I think is a lot more impactful when they are engaging other community members or working with legislators on advocacy initiatives, or, you know, trying to get individuals as clients through the door to work with community health workers. And so the video I shared, you'll get to see a lot of the individuals that we work with in their communities doing an initiative that really has been successful at bringing folks through the door for service connection with our CHWs, as well as other services that exist in community, while also addressing a very real need that has risen up across our state. And so in all of our products, we pretty much make sure that they're vetted by the community and have community voice within them.
Mhm.
And
Thank
Melissa,
you,
we have
Christina, and I see-
another, a question in the chat as well.
Yes. Yes, I do. And so I wanted to acknowledge one, the different ways that others have mentioned in the chat regarding the mechanisms that they're using, like listening sessions and face-to-face meetings. So in line with some of the other things that have been shared here, and encourage folks to take a look at that in the chat, as well as these valuable resources that Godwin and Christina have shared. As I transition to the question, which I see regarding these products and processes, which specifically is what processes do you use to test your products for appropriate health literacy levels? And also, how do you develop products in other languages? You know, for example, Spanish. And third, what challenges have you experienced with these two topics?
Yeah, I'm happy to kick things off. In terms of what processes have we used to test our products, I can speak to one framing that has been very helpful to us with a curriculum that was developed, actually forming kind of an advisory board made up of individuals from the community who review that content and have offered feedback to us, particularly because it was translated into Spanish. And so ensuring that we have that representation there to offer any guidance or feedback on how that is to be delivered and making sure that we're meeting the appropriate intention. And then in terms of what challenges we face with that, with work like that, I think one of the biggest highlights I would have to say would be always kind of having that concern surrounding what you might be missing, right? You want to do things with the best of intention. You think you're asking all the right questions, but at the end of the day, you want to make sure that you have the intents there and the impacts there, right? And so continuously keeping the lines of communication open on, is there anything we can be doing better? Does this appear as though it's meeting the intention? Are we missing anything? Throughout the process before a product even comes out is very critical.
Thank you, Jade.
I
I
would
think
say
that's a
Yeah,
great
I guess.
summary. I don't know if Godwin or Christine, if you want to
Yeah, I'll
add to
just go
that.
really quickly, especially about challenges, and kind of what we're looking at is we realize that there's a challenge because we just never traditionally been able to do really translations in a broad sense. I would say, speaking for the division of behavioral health. We had some one-off programs, WIC, for example, maybe a few others that did have translational ability, but it was expressed as a division in really multiple places within our government that said, hey, we need to better be able to translate services, especially since our legislatures are telling us, hey, we need to do this to the community. So they ended up passing a bill that not only tells us that we need to be able to have both interpretation as well as translational ability within our vital documents, as well as with the communities that we interact with, but then actually provided, so I think this was in 2021, and then I think 22 came around, we did a language access plan. It's like, this is nice, but we don't have any money for it. So this last legislative session, we actually was able to receive some money for that. And that's kind of where kind of that language access portion of, I guess, my title comes in, where I'm now looking to see kind of where are our gaps in services, working with the, I guess, with the community, and previous town halls that we've had with the community as large, to really understand kind of what we need, where we want to, I guess, take a portion of this money to be able to use it for. So great
Right.
question.
Well, you're mentioning a really great example there, Godwin, around how you're collaborating with your local policymakers to help support this work. So thank you for that. Christina, we were kind of running close to our time. Did you want to leave some space for you to add any reflections you have regarding those questions?
I think for us, it's really important to make sure that dialect is represented, and we're fortunate in that our team's pretty robust, and that we can have multiple colleagues review, particularly Spanish documents, to make sure that they, that the words translate across dialects. I think one of our biggest challenges is when we get into maybe some of the languages that are not as commonly written or don't have translators available. For instance, we have a large indigenous population here from Central America. A lot of people mistake the language as being a dialect of Spanish when it is actually a completely different indigenous language. And there are a lot of variations of languages coming from Central America. And so finding someone who can do that translation, we usually have to do it spoken, because a lot of times languages aren't always written. And so we usually are, translating from Quiche to Spanish to English, English to Spanish to Quiche, which gets to be a little bit of a process.
Right.
But I will tell you, community members are incredibly grateful when you put in the effort to do those things, even though it may seem tedious, it may take more time. Something that you wanted to only do in 30 minutes may end up taking 2 hours because of having to translate across languages. But the relationship you build in that process is invaluable. And then they know that you can be, a trusted resource in the future if that need arises. So
Absolutely. No, that's a really good point. The time frame, you have some flexibility in your time frame, but also that's a great example of engaging folks. So, and as I want to just acknowledge some of the additional resources that folks have put into the chat, specifically the language access plan that Maureen has included, and then the NC 360 that Terry Moore has included. And I know that we've got some additional, the next step that we've had, looks like there's also the CDC Clear Communications Index, and invite folks who are thinking of other resources, please use this as a space to share other resources in the chat as we transition to the next portion of the session, which, as Godwin said, we've been pretty didactic this portion of the conversation, but we're transitioning into breakouts so that we can individually in small groups have a chance to talk through other ways to incorporate bidirectional communication in our local communities. So I'm going to first thank our speakers, Godwin, Christina, and Jade. So please join me in a virtual applause for their willingness to share their experiences and challenges and successes as we transition to Alicia, who's going to take us through the next portion of our session.
Thank you so much, Melissa and Godwin and Jade and Christina. I thoroughly enjoyed the dialogue. I'm so happy to be here and was able to listen in on that. I'm happy to be gathered with everyone. I am Alicia Justice. I'm the Senior Director for Programmatic Health Equity Initiatives and Strategy at ASTHO on the FIS team, who you all have been interacting with to join this session today, in addition to our partners at CDCF and MPHI. I am an African-American woman with dark curly hair in a olive green shirt. So we are going to be moving into some breakouts so that we could hear more from you all and get an opportunity to hear about the work that you all have been doing from this same perspective, to learn from one another, share resources, and also have some opportunity to maybe even hear where you might be having some sticking points, and give you the opportunity to get some guidance from some of your community partners from all across the globe. So just after the sound of my voice, you all are going to be whisked away into a virtual breakout space where you will be gathered with a facilitator who's going to help with guiding that conversation with some guiding questions. But you are certainly not limited to just those questions. So please, if there are other things that you all would like to discuss that's related to this topic, utilize that space, own that space, take up space, and invite those ideas, those remarks, and any of those questions. We really want this community that we are building through these national convenings to be supportive and to be a safe haven place for you to get new ideas and to get resources. So with that, please stay on and join us in those breakout rooms so you can have some connection time and participate in some bidirectional communication.
Great. I think we have everybody back in the main room. We are going to have just a few minutes to reconvene and just maybe pull out some high level things that were discussed in the breakout rooms. Of course, you are more than welcome to come off mute, maybe one person from each room, or if you would like to add your response in the chat, something maybe that really stuck out to you, you're more than welcome to do that. I'm going to turn it over to Carrie. She is going to take us through this portion just to reconvene, and we'll end with the closing.
All right, so yes, thanks for those of you who were able to stay on and be a part of those working discussion groups. We do want these opportunities in these national convenings for you all to be able to actually have conversation and connect with folks in other parts of the country. So I wonder if there is a breakout room who would want to share back some key points about the conversation that they had in response to the questions or otherwise.
I can share. We ran out of time to designate a speaker, but I was a facilitator. But some of the main things that came out of our session really were about, we have these listening sessions, these webinars in place, but what do we do with this information once it's done? What is the community's role within these sessions, within these community engagement and events? And how can we show to them that, okay, we gather this information and this is the end result, this is what we can do. But with a lot of, and one person talked about community context assessments, but no one is doing anything with that information. It's stagnant, it's staying there. And so the community, from that, the community is hearing, you want us to speak, but nothing is getting done, which builds mistrust and anxiety. Although they might get compensated, it is wasting their time. And so really challenging leadership to, one, to actually care about what's going on and to get results and provide for the community. And then just turning the listening sessions, the webinars, these engagement tools into action. So that's what our group talked about.
Yeah, Alice, do you want to go ahead?
Absolutely. I had the distinct pleasure of being in a room as a facilitator, and it was so much rich conversation. 3 highlights I would like to share would be Michigan. I think she had to log off, but they did an amazing job with some of their equity dollars and hosting 11 focus group sessions, taking that data and communicating with the community actually about what the findings were in those engagements, and then opening up a funding opportunity through their Health Equity Council, and shared an amazing story about one of the citizens losing over 100 pounds as a part of wanting to, just altogether that geographical area wanting to focus on weight loss. And then we had, so basically Michigan, they're doing quite a bit around just communicating and re-engaging bi-directionally with their communities through their health equity councils. And then second, we had a rich conversation around questions like what are tools that are being utilized? And a key question was, how do you get leadership buy-in so that some of the things that, or ideas that were expressed with our panel that could be actually a reality for some of the others that are wanting to do the same. And so we talked about the importance of power and influence. And Godwin was quoted, how do we fail forward, right? And we need leadership buy-in and support and psych safety for that. And last but certainly not least, we had a resource in our room, and a lot of it is already in the chat about health literacy, but Maureen pointed us to all the work that's happening at CDC around health literacy. So if you can, pull those from the chat. And she was just able to really double down on that, and sharing how important it is that we, remember that it is the law to have access plan around plain language and health literacy. So thanks everyone for joining and be a part of that call. I'm sorry, that breakout.
Yeah. Yeah, curious to hear about that, more about the communication that went back after these focus groups, because I know that was a topic that was raised in our session as well, is about how to get to that action point. It's sometimes be a little bit more straightforward, maybe about how to get the input, and where the action opportunities are might be more challenging. Does someone else want to share out from their group?
Or do you want me to share a couple of things from our group?
Yeah, that'd be great, Christy. Thanks.
I think just playing off of, there's some similarities from what the other two groups have talked about, is moving from the listening to trying to find action points, even if, it's just trying to problem solve, whatever that is, but just trying to make sure that it's not just taking the information, oh, you're always gathering information, but nothing ever comes of it. So, trying to use those opportunities as trust building or relationship building. And, there's a little discussion around, moving from these more transactional relationships to transformational, and really making sure that there's that constant bi-directional communication happening. So if there is ever a question, or if there is an ask, it's not always perceived that, oh, they only reach out to us when they have a question or they need something from us. And, there's other points just around data. We had some EPI folks on, and, it's like trying to answer the questions communities might have and understanding that, and creating more of this iterative way of the data interpretation, sharing back with the community and making it more of a constant cycle instead of just a quick in, out, and then more moving on. Just, really trying to think about the relationship component of the work that's happening.
Thanks, Christy. Is there some other group that would like to share? We've got a couple minutes left here.
Yes, I
Hi.
can.
Go
Sorry,
ahead, Autumn. Go ahead, Autumn.
No. It's okay. You can go ahead.
Oh, okay, just real quickly, I was just gonna say that in my group, Stan Martin from Buffalo, New York, I would agree that there is tremendous synergy from our discussion that the other presenters before me have shared, and that in particular surrounding ensuring that as we're collecting surveys or we're doing any type of gathering of collection of data, that we are sharing that information back with the community and checking in and seeing if, did we get this right? Did we hear this right? Does it reflect your thoughts and attitudes and even your feelings surrounding, this particular initiative or health issue? So we did talk about the importance of that, and then also utilizing the framework. I'm not a stretch grantee. However, when you look at the framework that you all have outlined that you're working with, ensuring that the community remain centered and coming from a perspective that the community has the answer, and we're coming alongside them and we're meeting them where they're at when we have this bi-directional conversation, whether it's with engagement, being participatory, or some other perspective, that way we're ensuring that we're, that they're driving, they're the drivers and not we are driving the car, so to speak. So thank you.
Thank you, Stan. I also just led me to wonder, since that's come up a bit, if anyone has any resources they'd want to drop in the chat about how to share back with communities to make sure that you are understanding things right, that you are just getting that kind of affirmation or hearing what it is that they want to hear otherwise, or some other kinds of ways that you're taking action on what you hear. Autumn, was there anything you wanted to come in to say?
Oh, actually, our group ended up discussing similarly to what Stan just said, so I want to echo his comments as well. And then Christina from Hawaii was sharing that when they share data with the community, like Stan said, they make sure everyone in the community has like a basic understanding of the data, and they will often then ask the community sort of like the change they would like to see through the data and involve them. So an example she gave was like looking at attendance at the bus stop as an indicator of like school attendance. And then they'll have the community bring the data back to them, and then they'll post that data throughout the community.
That's a great example. One other person who'd like to either just jump into the conversation or share back something from their group?
Yeah, I can share really briefly. A lot of our conversation was around what was alluded to in the presentation, talking about culturally appropriate materials that are linguistically equitable for people who it's intended to reach. And so we even talked about getting down to the basic like dialects of different languages. And so more particularly, we talked about Spanish, and you know, everybody who speaks Spanish, or people who speak Spanish, they don't all speak the same language of Spanish, if you will. And so I'm really reiterating getting community voice and input on materials. And somebody said a newscast and anything that's going out to public facing, that information is linguistically and culturally appropriate, because if it is pertaining public health information that we want everyone to have, that is something that we want to incorporate into our work as well.
All right, I appreciate hearing all these similarities across the conversations today, and some ways that folks have been able to help each other out with some resources, maybe even in the chat. We can continue those conversations on the ASTHO site even. Valerie, do you want to then take it over for the last few minutes?
Absolutely. Thank you all so much for all of the, I like to use the word titillating conversation. This was great. Thank you so much to our speakers, Dr. Melissa Green. We had Jade, Christina, and Godwin all share perspectives, gracefully incorporating the Stretch 1.0 in our framework. And so if you want more information, or if you want more opportunities to connect with more public health practitioners, and more specifically within the Stretch network, I am going to drop a link in the chat to where you can join our Stretch network of health equity practitioners. And so this is like an open forum. You do need a my.astho account, which you can go ahead and use the one that you already used to register for this convening. And it's just an opportunity to share resources with everyone who is on the call. It's open to everybody within the US and territory. So great opportunity there. Please join if you would like. Also, I'm going to drop a link into the chat in case you, a link into the chat in case you want to access the evaluation that will populate once you leave the meeting. But here it is again, in case anybody needs it. We would love your feedback. You can do this by, of course, scanning the QR code. If you need to record your response via phone, please email ASTHO.org, and we can get your phone response as well if that's something that you need. Thank you all so much for being here for our second national convening. Please be on the lookout through ASTHO, dissemination of all sorts of mailers, social media. We will be having our third convening on workforce. So please be on the lookout for that convening in the near future. Thank you all so much for being here, and we will see you soon. Thank you.